But tonight we're going to be talking about breathlessness, and this is a really important topic because it has such a significant impact on how people feel. And I really like this quote from Tim Winton. It's funny, but you never really think much about breathing until it's all you ever think about. And it's so true, you know, like it's difficult to treat hypertension or renal impairment, but breathlessness affects people's lives so much. If we're able to do something for people who suffer with breathlessness, we can make a real significant impact to their quality of life. And it fits in nicely with sort of our mission from Lung and Sleep, which is to inspire and help as many people as possible improve their health with specialist attention to the treatment of their lung and sleep disorders. So our first speaker tonight is Sean Yeo, who's a respiratory and sleep physician who's joined us at Lung and Sleep, and he's going to be talking about the causes and mechanisms for breathlessness and what to test for. And Sean's in an excellent position to do this because he's also an expert in pulmonary hypertension, having done a year over in Canada last year studying this area. And the workup of breathlessness plays such an important role in managing patients with pulmonary hypertension. So Sean's really an expert to talk about this, so it's great to have him here tonight. And we're lucky to have him here tonight because he almost didn't get back because he was in Canada and got back to Melbourne between the first and second lockdowns last year. So he was able to squeeze back into the country. So we're very lucky to have him here, and we're certainly lucky to have him here to talk to us.
Yep. So thanks, Button, for the introduction, and thank you all for joining the talk today. And it's a great privilege to kick things off tonight. And I'll be talking about the causes and mechanisms for breathlessness and keeping things very clinically relevant. And also a bit about what tests to do and how the test would help us to work out possible organic causes for breathlessness in our patients. So breathlessness is also defined in medical literature as dyspnea, which literally means difficult breathing. And it's a subjective experience. And that's important because the sensation of breathlessness is influenced not only by physiological factors, but also psychological, social, and environmental factors. And anyone who's ever been to a HIIT class where the trainer is shouting you to do one more rep knows that it can be a very terrifying sensation of dyspnea. So this is a simple schematic which helps to visualize the different causes for breathlessness. It's also known as anatomy for respiratory physicians. So the system which allows us to exercise basically, in essence, delivers oxygen from the environment to the muscles by way of the lungs, which provide ventilation. So you're breathing in and out. So you're breathing in oxygen and you're expelling carbon dioxide. And there's the cardiovascular system, which is responsible for transporting that oxygen from the lungs, from the atmosphere, from the lungs to the bloodstream to exercising muscles, where it's metabolized and turned into energy. And red blood cells are important in transporting that oxygen. And lastly, the muscle is also obviously the important organ that allows us to perform exercise. And oxygen is then consumed and carbon dioxide is produced, and it's transported in the reverse direction from the muscle through the bloodstream and the heart to the alveoli and back to the atmosphere. So that's exercise in a nutshell. Now, obviously, I'm leaving out a very important organ, which is the brain, and it's because it controls breathing. So the breathing centers are located in our brainstem, which is why in normal conditions, breathing is subconscious. Most people don't think about their breathing all the time. And the breathing centers in the brainstem essentially serve to regulate carbon dioxide, oxygen, and pH in the blood, and most importantly, carbon dioxide, so that it serves as a thermostat, and we are very sensitive to any changes in CO2 in the blood, and it acts on chemoreceptors in the brainstem. Now that's at rest and in a healthy individual, but there are many other factors which can affect your breathing centers. So when you exercise, the movement of your muscles and the contraction and the movement of your joints actually send a signal to your brainstem to increase your breathing. And there's also receptors in your lungs and your airways, namely irritant receptors and stretch receptors. So these respond to any insult, such as fluid in the lungs from heart failure, a pulmonary embolus, inflammation from asthma, or infection from pneumonia. So these factors can all cause shortness of breath because of activation of these receptors in the lungs. And that happens way before there's any abnormalities in your oxygen, carbon dioxide, or pH. So if you were to test the CO2, oxygen, and pH in most patients who come through the door with or come through emergency with an asthma exacerbation or a PE or even heart failure, most of them actually are not hypoxic or hypercapnic or acidotic. So that's an important point to note. And as mentioned before, because it's a subjective conscious sensation, there are pathways between the cerebral cortex and the brainstem, and that can play a very important role in patients who have conditions like anxiety, where there is often a feedback loop between anxiety and shortness of breath and more anxiety. So delving in more into the organic causes for shortness of breath, in the respiratory system, obstructive pathology such as asthma, COPD, and bronchiectasis can affect the small airways, but also large airway diseases such as patients who have subglottic stenosis or a large goiter compressing their larynx or trachea can also feel breathless. Restrictive lung diseases such as interstitial lung disease, also known as pulmonary fibrosis, can cause shortness of breath. And diseases within the pleura, including pleural effusions and pneumothorax, are other important causes. Now, not only are the lungs important, the chest wall is equally important because it helps, the lungs rely on the chest wall muscles, the diaphragms and the intercostals to inspire and expire. So any problem which affects your chest wall, such as neuromuscular diseases like mononeuron disease or post-polio syndrome, can cause weakness of your respiratory muscles and shortness of breath. Patients who have significant amounts of adipose tissue, especially pushing up against the diaphragm or pressing down on their ribcage, can feel quite breathless. And lastly, any problems within this skeletal structure of the thorax, such as patients who have severe kyphoscoliosis, can also develop a restrictive pathology and breathlessness. And the interface between the heart and the lungs, which are the pulmonary vessels, may also be affected. So the most common pathology in this area would be pulmonary embolism, which tends to cause more acute shortness of breath, but there can also be chronic PEs. And pulmonary hypertension, although quite a rare condition, is an important and potentially a very sinister cause for shortness of breath in younger patients. Moving on to the heart, so the common causes would be heart failure and valvular heart disease. So in our population, most commonly severe aortic stenosis is an important valvular cause for shortness of breath. Ischemic heart disease tends to cause breathlessness associated with angina, but patients, as you know, with diabetes or neuropathy may not actually experience the angina and may present with silent ischemia that manifests as breathlessness. Arrhythmias, both tachy and bradyarrhythmias, can cause breathlessness, usually paroxysmal, and may or may not be associated with palpitations, lightheadedness, and syncope. Diseases of the pericardium, such as an effusion or constrictive pericarditis, are less common, but also very important causes. And as I mentioned, we need hemoglobin to transport the oxygen from our lungs to the muscles. So anemia is an important cause that needs to be ruled out. And moving on to the peripheries, so deconditioning is a very common problem within our society. And not only because patients who don't exercise as much put on weight and might get obese or overweight, but within the muscles themselves at the microscopic level, deconditioning actually causes less muscle blood vessel supply or less capillarization of the muscles. So there's actually an impairment in the ability of the muscles to absorb and take in oxygen because there's less blood vessels that supply the muscles. So this can actually be improved or reversed with rehabilitation and exercise. As mentioned before, neuromuscular diseases not only affect your respiratory muscles, but can also affect your peripheral muscles and cause exercise intolerance. And peripheral vascular disease, although it tends to cause more pain and claudication and occasionally ulcers and gangrene in the lower limbs, can sometimes be misinterpreted by patients as exercise intolerance because of leg fatigue. So if a patient has risk factors for vasculopathy and calf pain, they need to be investigated for peripheral vessel disease. And lastly, after talking about all the organic causes, there may be functional reasons why a patient may present with breathlessness. And the reason I put it in quotation marks is because it's such a complex symptom that you definitely want to make sure you've investigated and ruled out all the important organic causes before a patient is labeled as having functional breathlessness. So a good starting point to investigate patients who come in with breathlessness would be a chest X-ray, which might identify any overt pulmonary pathologies such as hyperinflation or pulmonary fibrosis or pleural effusion. And a patient with heart disease might have cardiomegaly on the chest X-ray, which is a clue to underlying heart failure. Lung function testing is important, specifically spirometry pre and post bronchodilator to look for reversibility, which might indicate asthma, and also a DLCO, which is also known as diffusing capacity, to assess the ability of the lungs to exchange gas. So lung function tests might identify an obstructive or restrictive lung disease, or occasionally you might see a patient who may have normal spirometry but a slightly low DLCO, which could be a clue to pulmonary vascular disease such as pulmonary hypertension or PE. And blood tests to rule out anemia is important, and also to check for possibly metabolic acidosis, because acidosis is a strong driver for shortness of breath. And conversely, a patient with metabolic alkalosis might have an underlying respiratory acidosis. So it could be a clue that they may have chronic hypoventilation, such as patients who are obese or have neuromuscular diseases. An echocardiogram is important to rule out left ventricular systolic dysfunction. It's not as good for diastolic dysfunction. It is quite a difficult assessment on echo. Also valvular heart disease and pulmonary hypertension. Now we often think of the RVSP or right ventricular systolic pressure as a marker for pulmonary hypertension, but the problem is, especially with transthoracic echo, that the RVSP measurement can sometimes be highly inaccurate. So a young patient who presents to you with shortness of breath and has a normal RVSP, but the right ventricle looks dilated, may actually have pulmonary hypertension, and it shouldn't be excluded based on a quote unquote normal RVSP. And of course, as you know, echo doesn't rule out ischemic heart disease. So to do that, the patient has to have a stress test or a CT coronary angiogram at least, and an ECG if you suspect an arrhythmia. Now, just to delve a bit more into lung function tests, so some patients think that a peak flow is adequate as a lung function test, but this diagram of the flow volume loops in normals and different diseases is a good illustration why it's not actually a good diagnostic tool. So when you do a peak flow measurement, what you're really measuring is the peak of the expiratory flow. So that tells you nothing about lung volumes. So a patient with a restrictive disease such as pulmonary fibrosis can actually generate very high peak expiratory flows, but their lung volumes are severely restricted. So that a normal peak flow shouldn't reassure you that their lungs are normal. And why do we do a DLCO when you can just do a handheld spirometer? Why do we put patients through a whole series of tests and measure their gas exchange? Now, this is a case I saw fairly recently. A patient who came in with fairly mild obstruction on his spirometry. His FEV1 to FVC ratio was reduced, but his FEV1 was 81%. But he was severely short of breath. And this was his CT scan. So he had severe emphysema, especially in the apex of his lungs, and pulmonary fibrosis at the basis. So this is a condition called combined pulmonary fibrosis and emphysema, or CPFE for short. And patients with this condition, as well as a few other uncommon conditions, can actually present with a very normal looking spirometry, sometimes even completely normal with no obstruction, but can have very severely impaired DLCOs. This would have been completely missed, especially if you do it by telehealth and you don't have the opportunity to listen to the patient's chest. and you just saw the spirometry results, you might be fooled to think that he doesn't have any pulmonary pathology. So if the initial series of tests do not provide a diagnosis for the breathlessness, then what do we do next? So a CT would be a good next step. And the question is, do you do a non-contrast HRCT chest or a CTPA? And that depends on whether you think the patient has an ILD, if they have crackles in your chest or an underlying connective tissue disease like rheumatoid arthritis or scleroderma, then a HRCT is better for assessing the lung parenchyma. But if it's a relatively acute onset of PE and the lungs sound clear on examination with a normal looking chest X-ray, then a CTPA is reasonable to rule out a pulmonary embolus. But a CTPA is not as sensitive as a VQ for ruling out chronic thromboembolic disease. And occasionally we do send patients for complex lung function testing, such as a mannitol provocation test, if we suspect asthma, but they don't have reversibility on a spirometry. That doesn't rule out asthma. So we would occasionally send a patient for a mannitol. And if there's a reduced vital capacity on spirometry, static lung volumes can help to confirm restriction. And in patients who have neuromuscular diseases, maximum inspiratory and expiratory pressures may help to quantify the degree of weakness. A sleep study, if we suspect chronic hypoventilation, and the clue to this would be metabolic alkalosis, chronic daytime hypoxia, or if they have polycythemia or pulmonary hypertension. And cardiologists would usually undertake a stress echo or a nuclear medicine scan to rule out ischemic heart disease, or a CT coronary angiogram and a calcium score, and Holter if there is suspicion for a paroxysmal arrhythmia. And more specialized tests, which are less commonly undertaken, include a cardiopulmonary exercise test. So this gives an objective measure of fitness and also gives us a clue as to whether it's a cardiac limitation or a pulmonary limitation for their breathlessness. And also gives a clue as to whether there could be deconditioning as a major contributor for the symptoms. And a very specialized test is an exercise right heart catheterization. And this is very rarely undertaken and only usually in quaternary centers to look for conditions like exercise-induced pulmonary hypertension, which is still a fairly elusive condition that's hard to diagnose. And HFpEF, which is a lot more common, but also surprisingly hard to diagnose. So occasionally patients get referred for an exercise heart cath to look for HFpEF. So just to summarize my talk, breathlessness is a subjective sensation. So it's not like tachycardia or hypertension or hypotension. Breathlessness or respiratory rate is a sign that has a lot of subjective conscious sensation and therefore a very complex interplay. There's multiple possible causes, and that could be pathology in the heart, lungs, or the peripheral muscles. And you need to investigate for these causes before labeling someone as having functional breathlessness. And a normal oxygen level or blood gas should not exclude cardiopulmonary diseases. Basic tests identify most patients with shortness of breath. So this includes a chest X-ray, lung function, bloods, and echo. But there is quite a number of patients who come through our rooms who have breathlessness that are not explained by these static tests and usually have to go for more advanced investigations. So with that, I come to the end of my talk and I'll hand it back to Barton.
Excellent. Thank you very much for showing that, Sean. That was a really terrific talk. I think I might like to get your slides actually. They're good graphics and really nice explanation of the mechanisms of breathing, and then what should we do when someone we're faced with that is breathless. I am just going to share my screen again now, and while I'm doing that, in the chat, I've got a very good question from Ron and just asking about the HRCT, and I think that HRCT is sort of a little bit of an old-fashioned term for high-resolution CT, because as Ron quite correctly points out, CTs are all high-resolution these days. The thing is that when they do a traditional HRCT chest, they're actually doing non-contrast, and they're doing it in different ways. So they will do a CT with the patient breathing in. They'll then do CT with on expiration, and then they'll do a CT with the patient in the prone position as well. And the prone position is to see if there's any abnormality around the lung base that might be dependent because the patient's on their back during the scan. And doing an expiration view can also tell us about small airways and to see if there's gas trapping. So it's very good at looking at the pulmonary parenchyma, and it's very good at diagnosing interstitial lung diseases. Where a CT with contrast is not so good at actually looking at the lung tissue itself. It's much better at looking for lung lesions, lung cancers, and mediastinal problems like lymph nodes and stuff like that. So I think we had a few people join just during Sean's talk. So welcome to those people who have joined. Please open up the chat feature in your Zoom and feel free to throw questions in there as we go, and we'll continue to answer those. So Sean has given us a very good idea of what the causes for breathlessness are. And the things that I think of, as Sean pointed out, when the tests are normal, diastolic dysfunction is something that can be missed. Asthma can be missed with normal lung function. Pulmonary hypertension, we always need to think about. Deconditioning is very common. I'm just going to touch a little bit more about dysfunctional breathing and vocal cord dysfunction. People describe breathlessness differently though, and Sean touched on this really nicely. And I think that if you talk to patients, people will describe it differently. And sometimes people talk about being frightened, worried, helpless, like there's something smothering them. They might feel constricted or suffocating. And sometimes people describe an air hunger. And sometimes what they describe can sort of give you a bit of an idea as to what's going on. And I like Sean's analogy of the trainer during the high intensity exercise telling you to go a little bit harder, and it certainly gives you the feeling probably like what these guys have. Guys like this, they don't describe breathlessness, they actually describe pain. So when you're exercising to a point where you're so breathless, sometimes people actually describe it as pain. But vocal cord dysfunction is something useful to think about. Now, I always think that if you have someone with breathlessness and you do the test, as Sean really nicely explained, and most of the time that will diagnose the cause of the breathlessness. And then it's quite easy because once you have the cause, then the treatment is relatively straightforward. However, sometimes it's more difficult to find the cause, and sometimes all the tests are normal. And the things I think about in that situation, one of them is vocal cord dysfunction. And so what happens with the vocal cords is that they hang down like this, and as we breathe in, they open up, and as we breathe out, they narrow just a little bit. Sometimes though, what happens is you get patients that their vocal cords close excessively during breathing in and sometimes even during breathing out. And it causes difficulty with breathing. And often these people talk about they feel like they're suffocating, they feel like they're choking, they can't get their breath. Often this occurs in response to something. So the typical ones are like strong smells. So the patient who walks into the pharmacy and suddenly gets really breathless, but then leaves the pharmacy and later on that day is completely fine. And so severe brief episodes of breathlessness, often brought on by something. Sometimes it's brought on by asthma, exercise. So I saw a young girl just recently who was a very good runner, but she was starting to have problems with her running. When she'd run 100 meters, she'd do it a couple of times without any problem at all. And then maybe on the third run, she'd get this sudden breathlessness and she couldn't keep going. But then later on that night, she'd be fine. And she was having exercise-induced vocal cord dysfunction. The clues to it is that people often describe difficulty breathing in, where the typical asthma or airflow obstruction causes difficulty breathing out. Sometimes it's worse when people are talking. Sometimes it's associated with a change in their voice. They often have rapid onset and rapid improvement. And it can be certainly exacerbated some things. And although the flow volume loop I've put there shows some flattening of the flow volume loop, often the lung function is done at a time when the patient is not symptomatic, so we don't see that. So usually lung function is normal. It's often associated with dysfunctional breathing. And I'm sure that everybody has seen patients with dysfunctional breathing. When they come in and they're breathing with their shoulders like this, and there's a lot of movement of the upper chest, a lot of movement of the shoulders when they're breathing. Often occurs in people with lung disease who have difficulty breathing already, but often in people who have no underlying lung disease at all. It happens to everybody from time to time. It happens when people are anxious. And so have you ever had the experience where you get up on stage and talk in front of a group of people, and you start to feel a little bit breathless and you start to shallow breathe. Well, what's happening is that you're changing your breathing pattern. So this is useful to know because this is not a lung disease. It's not a heart disease. There's no underlying organic pathology, but people can change their pattern of breathing, and that can cause them to have a significant breathing problem. And so when it's useful to recognize this, because once we recognize it, we can manage it with some breathing exercises. Often patients recognize that that's what's happening and they become reassured and it starts to settle down. And so I think what often happens is the vocal cords start to narrow. That causes people to get breathless. When they get breathless, they start to pull the air in from the top of the chest rather than breathing from the diaphragm. When they're pulling the air in from the top of the chest, it's inefficient. That makes them more breathless. And when they're more breathless, they feel anxious. And anxiety is a completely normal reaction to breathlessness. Feeling short of breath is very anxiety provoking. And so it's a normal reaction, but it stirs the whole thing on. And it becomes a bit of a vicious cycle because then often their vocal cords close further, they develop more dysfunctional breathing, and it's a bit of a vicious cycle until something settles that cycle down and breaks it, and then it settles down and they'll often go back to their normal pattern of breathing. And so recognizing it is really useful. And what I get people to do is put a hand on the chest and a hand on the tummy. And usually in the rooms, I get them to do it whilst just resting back in their chair, but it's best lying down because it's easiest. And I get them to take some big breaths and to look to see which hand is moving more. And if they've got significant dysfunctional breathing, it'll look like they're moving their top hand. So if I stand like this, it's sort of like, often with the shoulders moving up, sometimes with the tummy moving in. And what we want to see is that when they breathe in, there's relax across the shoulders, relax across the top of the chest, and they push their tummy out. And so what it should look like is like that. And I get people to do this, and I teach them how to do it, and I ask them to do it for 10 minutes twice a day to practice getting used to the feeling. And people actually can get better at it. And then when they feel breathless and they get the symptoms, if they concentrate on their breathing, recognize that they're breathing in a dysfunctional way, they can start to turn it around, breathe from the diaphragm, and often settle down their breathing by themselves. And then if they settle their breathing down by themselves, it's reassuring to them that they can control this and there's not any underlying nasty disease. If this doesn't work, then the next step is definitely to get them to see a respiratory physio. And so I introduced at the start, but for everybody, we have Leah and Ali, who are both expert respiratory physiotherapists who practice from our rooms in Bentley Specialist Centre. And Leah now is going to take over from me and tell us a little bit more about what happens with people's breathing, what happens when people develop this dysfunctional pattern of breathing, and what can we do for these people who have breathlessness, but there's not a clear abnormal underlying condition.
Lovely.
So Leah.
Thank you very much, Barton, for that kind introduction. I am going to move into sharing my screen. So as Barton said, I am one of the respiratory physiotherapists that work at Bentley Specialist Centre, and along with Ali Kavanagh, we have a practice called Lung Life Physio. So in some of my week, I'm the practice manager, but my passion is actually in respiratory physiotherapy. So today I'm going to talk to you just a little bit about what respiratory physiotherapists do and how we treat breathlessness without medication, but often as with an adjunct to medication and medical management. So this is Ali and I. And I guess to give you a little bit of a background, we're physios, both with a combined working experience in giving respiratory care for around 30 years. So we have postgraduate specialisation. So I have a clinical master's of cardiothoracic physiotherapy, and Ali has a master's of research, and her area of specialty is in respiratory and geriatrics. We are also both certified Bradcliffe practitioners, and that is a Bradcliffe breathing method that is used to treat people of all ages who have dysfunctional breathing. So I guess one of the main things for physiotherapy, it is a little bit different to normal physiotherapy. So we treat many important lung conditions. One of our main practices is around airway clearance, particularly in COPD and bronchiectasis. We spend a lot of time managing difficult breathing patterns of patients. A lot of patients who have irritable coughs, and it's probably one of the most frustrating things for patients, and trying to work out how to treat the irritable cough, often post-viral, that just doesn't go away. And we provide a lot of education on inhaler, nebulizer education. And like I said, we do provide an adjunct to therapy for medical management. So what is it that we actually do for the breathless person? And I guess, which Sean and Barton have both touched on really nicely, is it's really important to understand the linkages between thinking and feeling and experience, the biomechanical factors, the biomedical factors with physiological factors, and the psychological factors. And there is a really, really fine interplay between all of those dynamics. And one of the really difficult things with patients or for people to understand who are breathless is that sometimes there isn't a biomechanical factor, or sometimes there isn't a biochemical factor, and sometimes it is an anxiety or more of a psychological breathing dysfunction. But the important thing to know is that if those things aren't managed properly, then we do tend to see a change in physiology and mechanics, and this leads to breathing pattern disorders. So what do actual breathing pattern disorders look like? And both Barton and Sean have touched on it really nicely, but they are patients who report really varying symptoms, and they're often quite fine symptoms. So often patients have a very hoarse voice, frequent yawning and sighing, and a really key sign is a lot of patients with dysfunctional breathing are mouth breathers. Patients will often report headaches, neck pain, and that's caused by that apical breathing pattern which Barton demonstrated. Often, but they will also have an upset gut, nausea, reflux. As one of the other symptoms is that anxiety, the panic attacks. You can get cough, sputum, and you can also get the other symptom that patients often don't even realise that they have is a throat clearing. So they do that where they're constantly kind of clearing their throat without even realising they're doing it. Some patients have a wheeze or strata and many don't. So what do we actually assess when we're looking at these patients is really the pattern of breathing. And as Barton discussed, we look at that apical pattern versus the diaphragmatic pattern, and that's probably one of the most important and the best place to start with treatment. The other area that we look at really closely is the pattern of breathing through the nose or the mouth. A nasal patency assessment. So we look really closely at the sinuses and how people are actually breathing, how they're clearing their nasal passages. The other thing that you will often see, which Barton again touched on, was speech. So often people have a husky voice and the throat clearing, but people who have a dysfunctional breathing pattern will often speak really fast. So you'll see them do and they'll talk as fast as I can, and then they'll take another big, and then they start again. And they're often people who are very, very used to presenting with a very fast speech pattern. We obviously do a musculoskeletal assessment, and posture is really important. There is also a questionnaire that we use as physios called the Nijmegen, and that is a questionnaire that patients are able to fill out pre-treatment and then post-treatment, which gives us a really good indication of whether or not they have a dysfunctional breathing pattern. So how do we treat it? The first thing and the most important thing is really education, education, and more education. So our patients need to understand that it is a real problem, and it's a really important problem to fix, because if we don't fix the breathing pattern, then it leads to more and more problems going forward. We do use the Bradcliffe breathing method, Like Barton spoke about, where he starts with teaching patients to diaphragmatic breathe, we do a lot of breathing retraining. We usually start in supine, as Barton suggested. We progress to sitting and standing and exercise. It's really important to know too, we see a really wide range from adolescents through to elderly people with breathing dysfunction. And there is quite a lot of people around that 30, 40-year-old age group that do present with breathing dysfunction. One of the other things we can do is try to increase the strength of the diaphragm. So often if people have had a dysfunctional breathing pattern for a significant period of time, you do lose strength in the diaphragm. So we use techniques to increase the strength of the diaphragm again. And sometimes that involves using inspiratory muscle retrainers. Relaxation is super important, along with nasal treatment. They then go home with a home program. And it's often, if they have a combination of issues requiring airway clearance, we sometimes have to treat both of those at the same time. So that is, in a nutshell, what a respiratory physiotherapist does, particularly with dysfunctional breathing. And I will hand you over to Ali now, who's just got a couple of very short case studies to share with you.
Excellent. Thank you, Leah. I especially like your demonstration of the person talking with dysfunctional breathing. Ali, if you can bring up your slides for your case. Just while you're doing that, just had a really good question from Richard about the Buteyko method. Can you comment on, Leah, while Ali is bringing her slides up, about how Buteyko fits in?
Look, there's a couple of different breathing techniques. Buteyko is quite an older breathing technique. I guess my feeling on it is that there is lots of different ways we can treat this. And I think over time, breathing pattern retraining, when I went to uni, breathing pattern retraining wasn't something that we learnt about. It was absolutely put on the back burner. And it is something that has come around again, particularly in probably the last 5 years, in terms of being something that is really, really important. So whether there is a couple of different breathing pattern retraining methods you can use, most work. The most important thing though is having the commitment from the patient to actually see it through, because breathing pattern retraining, there's no quick fix to it. And that's probably the really important thing for people to know, is that it takes time and it takes commitment. So I guess from my perspective, having not taught a lot of people or known a lot of people who use Buteyko, I have absolutely no issue which breathing pattern retraining you use.
Do you think probably that Buteyko was maybe ahead of its time, because it's been around for a long time and a lot of people have had a lot of success with it? And I remember during my training, it had sort of gone out of favour and people really basically said, oh, it's a whole lot of rubbish, and not to take too much notice of it. And now I think it's certainly come back and we recognise it more, and maybe what we're doing now is just an extension of what has been done in the past and fine-tuning it.
Absolutely agree. I think there was for just a period of time where we really put things on the back burner, but they're absolutely needed.
Yeah, I'll pitch in here as well. I haven't come across evidence that really supports the Buteyko method. I think also with the way that the Buteyko method was founded on was looking at correcting those carbon dioxide levels in the blood because of presumed hyperventilation. And when you talk about everyday breathing pattern, you need more than a prescribed way of breathing. We are looking at how the breathing muscles, the diaphragm and the chest wall muscles, the neck muscles, how they synchronize and work with each other. So it is a functional, exactly what it is, a functional problem. First is a 72-year-old male who was referred by, let me just check that my slides are going. Yes, he was referred by his GP to see one of the respiratory physicians at Lung and Sleep. And, they were asking for a second opinion because he was diagnosed with asthma in 2017. But he just had this ongoing shortness of breath and wheeze. He didn't really have a response to medications. He's had no family history of asthma, and all his other comorbidities, were checked out fine. He had a cardiac workup and that was all clear. So he saw one of our doctors at the Breathlessness Specialist Center. They ordered a pulmonary function test, which actually showed no airflow limitations. So that really questioned the diagnosis of asthma. He then had a bronchoscopy where excessive dynamic airway collapse, that's what the EDAC abbreviation is. So he had excessive dynamic airway collapse where, basically the airways did, there was closure of the airways early, on expiration. So maybe he did have some mild asthma, but certainly out of proportion to his symptoms. So all his respiratory medications were seized, and then he was referred to respiratory physio. So when he came to me, his Nijmegen questionnaire score was 29. So anything over the score of 19, we are looking at a likely dysfunctional breathing pattern. And, when you observed his breathing pattern, he definitely had that very dominant upper chest, breathing pattern. But also, as, you just observed moving around the room and talking, he had episodes of just really brief breath holding. And every now and again, he would just have this sigh, which he didn't realize he was doing. But, you could observe that happening from time to time. He said to me, I can't even put my shoes on without getting puffed. And, he was a man with a good heart and he wanted to volunteer to look after an entire estate, the outdoor gardens and just, maintenance. So his physiotherapy consisted of purely breathing retraining. He didn't have any sputum clearance issues. And basically, like Leah said, we started with basic diaphragmatic breathing. And, by retraining and getting him to learn diaphragmatic breathing, it really increases awareness of his ability to actually evaluate his breathing pattern, and then give him the skills to be able to reset. So we started this just, in lying, it progressed to sitting, to standing, which becomes more and more challenging for the body because the diaphragm then has to contribute to postural, responsibilities as well. We then, once he could, set diaphragmatic breathing in static positions, we started to see whether he could do it whilst doing some light activities. So I decided to go straight for, let's bend down, tie your shoelaces, but we added in an additional breathing technique, which we call breath pacing. So this is where we then, sort of similar to the Buteyko method, where you put, we set an inhale to exhale ratio to ensure that he is not breath holding or breath stacking. But as he does that, he knows to do that but through diaphragmatic breathing and not by using his upper chest. So we started to apply this combined strategy to different daily activities that he would do. And by this point, with practice and practice, looking at 3 months of rehabilitation down the track, and he had significant symptom reduction. And if he did get symptoms, they were much less intense, which are much quicker, faster recovery. So you can get, you get the idea here that his quality of life is already changing, quite a bit. We are now at 6.5 months of rehabilitation. He has progressed on to an inspiratory muscle trainer. So this is where we start to then add that resistance load to challenge the diaphragm to continue being the driver of breathing. And he has been persistent with that. And he now has no symptoms that he can easily identify unless you really quiz him on it. His Nijmegen has come right down to 17, which no longer indicates a breathing dysfunction. So he has done really well with that.
That's excellent, Ellie. Just before you go on to the next one, it might be useful just to concentrate on that for a little bit because I think it illustrates some really useful points. And one of those is that often it's patients with underlying lung disease that also develop this dysfunctional breathing. And as you pointed out in this case, although this patient may have had asthma, and sometimes it's difficult to tell whether there's a bit of asthma in the background, and often there probably is, and it might be a bit of asthma in the background that is actually the initial catalyst for causing them to have difficulties with their breathing, but then the adaptation to that goes into this cycle of sort of dysfunctional breathing, and that's what's contributing significantly to their symptoms. And because it's difficult to recognize, I think that often these people self-medicate with Ventolin because they think it's their asthma, and when it's not getting better, it's a bit of a clue to maybe there's something else going on. We've also got a question here, a very good question from Susie, to ask if you could explain to us a little bit more about the scoring system that you used, which I actually can't even pronounce. Nijmegen, is that right?
Nijmegen.
So firstly, how do you say it? And then what is it?
Do you want me to take this one?
Yeah.
So the Nijmegen questionnaire lists, and we can probably, I think, Leah, we can probably post a link to the actual questionnaire, but it basically lists a cluster of symptoms that are typical of dysfunctional breathing, and you'll be surprised, they're not just respiratory related symptoms. So it does cover things like, chest pain, but it's also got on there tingling of fingers. So they, more than just the respiratory based symptoms. And the patient then has to rate how often they experience each of these symptoms. So it goes from 0 being never, 1 rare, 2 occasionally, 3 you're looking at sometimes, which is pretty much daily, and then above that up to 5. So you total the score and it gives you a total score out of 64. So anything above 19, you're looking at, a likely dysfunctional breathing pattern. And that's not to say that it's just dysfunctional breathing. They can have dysfunctional breathing on top of, chronic lung disease as well. Like almost all my patients, who have, difficult asthma to manage also have dysfunctional breathing pattern. The questionnaire will also ask how many, about the severity of symptoms. So how many symptoms are scoring, 3 or more, and that in itself can also, so if they get a low total score, but they do get 3 or more symptoms that are quite frequent, that could also indicate dysfunctional breathing pattern. So it's quite
so
a
it gives a bit of a
quite a straightforward tool. Yeah.
So Mark's got a good question about the possible dysfunctional breathing as a cause for recurrent throat clearing and cough. What do you think about that, Leah? Ali?
Sorry, Barton, was that around the dysfunctional breathing?
A challenging patient with possible dysfunctional breathing as a cause for recurrent throat clearing and cough.
So I think we often see patients with dysfunctional breathing, and the main cause of the throat clearing is often the nasal patency and issues around nasal patency. So patients get really dry, often with just dysfunctional breathing, are mouth breathers also. So when people are mouth breathers, they become very, very dry. So the nasal passage is obviously incredibly important for humidifying the air. And rotating and cycling the air through our nasal passage before it comes into our lungs. So the throat clearing is a combination of things. Occasionally it is because of the dryness of the air coming through, but sometimes it is because of even close to a postnasal drip, where you're just getting this constant kind of dribble down the back of your nose. So with dysfunctional breathing, one of the most first things we really need to do is assess the patency of the nasal passage and implement strategies to correct the breathing pattern through the nose, and also ensure that it is humidified and cleared effectively. Have you got anything else to add on that, Ali?
No, not for me.
Yeah. Does that answer it, Mark? Super.
Thank you, Irene. Irene is saying it's nice to meet the rest of the team. It is nice to have other speakers to keep things interesting. And it's also interesting to hear different perspectives, and also especially physiotherapists therapy perspectives. I wonder whether, I suspect that respiratory physiotherapy is probably something that's a little bit under-recognised, because everybody thinks of physiotherapy as being very musculoskeletal, as sort of the mainstream physiotherapy. And I guess we know a lot about pulmonary rehab, but I saw someone today that had been to pulmonary rehab but didn't like that group sort of context, and really wanted to have some more one-on-one expertise. And so respiratory physio was going to be perfect, I hope.
Rehab's fantastic for a large group of patients, but there is certainly a subset, particularly our younger population too, who it doesn't necessarily suit them. And I think one of the things we are able to do is we can obviously see patients from referrals from respiratory physicians. Patients can self-refer, but we can also see patients referred through our local GPs. For our country practice GPs, there's also, we can obviously see patients through Telehealth. We have had some patients come to Melbourne to see us. And then often just with a couple of sessions, we are able to set people up and then link them back into the local services. And particularly in, I think Traralgon, LRH have a couple of physios there who are quite highly skilled in respiratory physiotherapy. So we can help to link that process back in.
I've got another question here from Ron that maybe Sean can answer, because Sean has actually been a part of the Pleural service at Monash, and he's running a brand new Pleural clinic at Monash. And the question is about spontaneous pneumothorax. And Ron had a patient who had a pneumothorax with almost completely collapsed lung from a spontaneous pneumothorax, and was sent home with conservative treatment, explaining at 6 weeks the lung will reinflate without risk of bleeding or infection, without the need for a chest tube. Is this now the new recommended treatment?
Thanks for the question, Ron, for the plug for the Pleural Clinic, Barton. So I think it's based on the study, an Australian study actually, which was published not long ago in the New England Journal, looking at conservative versus invasive treatment for spontaneous pneumothoraces. And the premise for that is that most patients, young patients who don't have underlying lung disease, who develop a spontaneous pneumothorax, actually can recover spontaneously without needing a chest tube, and therefore might be spared the complications of having a chest tube insertion. And that study actually showed, if you're interested, I can send the link to you from the New England Journal. It showed that patients who had the conservative management actually had non-inferior outcomes compared to those who had the invasive chest tube treatment for the pneumothorax. And they found that at 8 weeks of follow-up, the rate of re-expansion, complete re-expansion, was about 94 to 95% in both groups, and there was no significant difference. So that has changed the paradigm of treatment a bit in emergency. So patients who are stable with a spontaneous pneumothorax can actually be managed conservatively. And then we actually see a lot of referrals for follow-up in the Pleural clinic from emergency for conservatively managed patients. Now, that being said, obviously, the clinical assessment at the time is vital, and any patients with signs of instability, so severe dyspnea, hypoxia, hypotension, any red flags would warrant a chest drain insertion, and shouldn't be treated conservatively. And patients who were enrolled in this study were hemodynamically stable, and also stable from a respiratory perspective before they were sent home with the pneumothorax. So I hope that answers your.
So Sean, should we be sending patients to the emergency department who have a spontaneous pneumothorax?
Well, my opinion is, yeah, they should probably still have an assessment because you want to make sure, and often they get observed in emergency in short stay. They don't get sent directly home. So either an observation for a few hours, or at times overnight, to make sure they're stable before they get sent home from emergency. So I would advocate that, yes, they should still go to emergency for a spontaneous pneumo.
Very good. Anything else? Otherwise, I think we should wrap it up there and thank everyone once again very much for coming tonight to listen. Hopefully it's been useful. Hopefully you've learned something and it's been a little bit entertaining, which is the main thing. And we're keen to do it again. So as I said, I'll be really grateful if people were able to send this out or tell their friends and colleagues or doctors in your clinic who may be interested and may be able to come along as well. Would be really fantastic. So on that note, I will say good night.